Welcome back to the Deep Dive, where we take your shared stack of highly specific, critical research.
Yeah, the stuff you really need to get a handle on.
Exactly. And we cut through the complexity. Our mission, as always, is to deliver those essential insights, the need-to-knows, and maybe those aha moments that stick with you.
And today, well, we are charting a course through a really urgent and, frankly, measurement-driven corner of medicine, vascular health.
Yeah.
This isn't just about chronic illness. It's the whole spectrum, from those slow-motion internal threats to immediate catastrophic trauma.
Right.
We're covering aneurysms, acute limb emergencies, systemic arterial disease. It's a field where, honestly, swift diagnosis, accurate classification, specific measurements, they're literally life or death decisions.
That distinction you mentioned between a chronic issue slowly brewing and an acute tearing catastrophe, that really defines this subject, doesn't it?
It absolutely does. The specificity needed is incredible.
So our deep dive today is going to uncover those critical distinctions. We'll look at abdominal aortic aneurysms, or AAA.
Then aortic dissection. Terrifying stuff.
Definitely. Peripheral artery disease, those critical time constraints in acute limb emergencies. And we'll even touch on the ethical frameworks guiding treatment choices in these really high-pressure situations.
Sounds good. Let's jump in.
All right. Let's start with aneurysms, maybe the most common and often the most insidious of those slow-growing threats. So when we talk about an aneurysm, what are we actually looking at? The sources define it pretty simply. A focal dilation of an artery due to vessel wall weakness.
Right. Simple definition, but it hides a complex mechanical breakdown happening inside.
So what exactly is going wrong? Why does the artery wall balloon out like that?
Well, the problem really lies in the middle layer of the artery, the tunica media.
Okay.
Arteries are constantly under high pressure, right? And the median is what gives it strength, mostly through its elastic components and smooth muscle cells. In an aneurysm, you see this chronic degeneration. The elastic proteins, like elastin and collagen, they start breaking down. Enzymes, often linked to inflammation or risk factors like smoking, degrade these key components.
And when those foundational bits fail?
Exactly. The wall just can't withstand the constant pressure anymore. It weakens progressively, and then it dilates, balloons out.
And, while aneurysms can technically happen anywhere, the vast majority crop up in a very specific spot, the infrarenal aorta.
That's right, below where the kidney arteries branch off.
Why there? Why is that specific location so prone to failure?
It's really a combination of structure and stress. That infrarenal segment, it has a distinct physiological disadvantage. It has fewer vasa vasorum.
Okay, maybe unpack vasa vasorum for us quickly.
Sure. Vasa vasorum literally means vessels of the vessels. They're tiny blood vessels that supply oxygen and nutrients directly to the thick walls of big arteries, like the aorta itself.
Because the wall's too thick to get everything from the blood flowing through the middle.
Precisely. And the infrarenal segment, well, it relies less on this dedicated external blood supply compared to other parts.
Ah, okay.
So you've got poor nutrient supply combined with the usual biomechanical forces and actually higher wall stress in that lower section.
Yeah.
It just makes the area inherently weaker, more susceptible to that degenerative process we talked about.
So it's fundamentally a high-stress, low-support weak point.
That's a great way to put it, yeah.
That context really helps understand why it happens there. Okay, let's talk risk factors for this most common type, the AAA. We have the usual suspects, the non-modifiable ones, getting older, say over 60.
Right. Male sex, that's a big one too. And family history. If it runs in the family, your risk goes up.
But then there's the modifiable risk, the one that, according to the sources, really overshadows the others.
Oh, without a doubt, it's smoking.
Yeah.
Smoking isn't just a risk for developing in AAA, it's the absolute strongest predictor of progression once an aneurysm is there.
So it makes it grow faster.
Exactly. Those chemicals in tobacco smoke directly promote that enzymatic breakdown of elastin we mentioned earlier. So for any patient diagnosed with an AAA, doesn't matter the size, quitting smoking is the single most critical thing they can do. Our sources are very clear on that.
And then we get to that fact that always seems counterintuitive, that aha moment, or maybe moment, the paradoxical protective factor.
Right. Diabetes mellitus. You normally think diabetes is bad news for all arteries, atherosclerosis and all that.
Absolutely.
Yet the data consistently shows DM seems to offer some protection against developing in AAA. It's highly unusual, and frankly, the mechanism isn't fully understood.
I find that fascinating because it just cuts against the simple narrative. If the mechanism isn't clear, are there any leading theories in the sources? Why might diabetes protect here?
Well, the theories often circle around changes in the aortic wall structure itself, the extracellular matrix.
Hmm?
One idea is that those advanced glycation end products, AGEs, basically sugar reacting with proteins, might actually increase collagen cross-linking. This could make the aortic wall stiffer, maybe more resistant to dilation, kind of counteracting the elastic breakdown.
So stiffer in a potentially good way in this specific context.
Potentially, yes. Another theory suggests diabetics might have lower levels of those specific matrix middle proteinase enzymes, the ones that chew up elastin. It really forces you to recognize that the plaque-based disease, like PAD, which we'll get to, is different from the primarily degenerative inflammatory mechanism driving AAA.
That's a crucial distinction. Okay, let's touch on peripheral aneurysms. We can't forget those
Yeah,
because they often flag the bigger aortic problem,
absolutely. They're an important signal.
which is the most common peripheral type.
That would be the popliteal artery aneurysm, PAA, behind the knee.
Okay.
And a really striking detail here is the strong male predominance, something like 95% of cases are in men. But the critical takeaway for practice is the need for cross-screening. PAA and femoral artery aneurysms, FAA, they often coexist with AAA. So if you find a PAA in one leg,
You have to look elsewhere.
mandatory. You must image the abdominal aorta and the other popliteal artery because the chance of finding another aneurysm is really high.
Okay, good clinical pearl. Let's talk presentation. Most AAAs are silent killers, right? Found by accident on a scan for something else, or maybe a doctor feels a pulsatile mass during an exam.
That's very common, incidental finding.
But when symptoms do start, even without a full rupture, that's a major warning sign.
Definitely. Pain usually means the aneurysm is expanding rapidly, maybe leaking a bit, and the location of that pain is key.
How so?
Well, if the patient describes pain high up upper abdomen, flank, backward, the aneurysm is often proximal near the renal arteries.
Okay.
If the pain is lower down, lower abdomen or groin, it suggests a more distal AAA, maybe near where the aorta splits into the iliac arteries.
And that pain, or just finding the aneurysm on a scan, pushes us towards deciding on intervention. And the thresholds are incredibly precise. What are the size criteria that generally mandate elective repair?
Yeah, we use strict size criteria because the rupture risk climbs dramatically past certain points. For men, the threshold for elective repair is generally 5.5 centimeters.
Okay.
For women, who usually have smaller aortas to begin with, the threshold is often a bit lower, say 5.0 centimeters.
And size isn't the only factor, right? Growth rate matters too.
Absolutely. Repair is also indicated if the aneurysm is growing rapidly. The specific number cited is expansion greater than 1 centimeter within a single year, even if the absolute size is still below that 5.5 or 5.0 mark.
So if it's smaller than that and not growing fast.
Then it's active surveillance. Usually serial abdominal ultrasounds, maybe every 6 or 12 months, depending on the size.
Got it. Now let's talk about the catastrophe everyone wants to avoid. Rupture. Describe the classic presentation. What does that look like?
Rupture is often a classic triad, though you might not see all three parts if the patient is really unstable. But typically, it's sudden, excruciatingly severe abdominal or back pain, often described as tearing,
Okay.
then hypotension or outright shock because they're bleeding internally fast.
Right.
And third, sometimes you can still feel that pulsatile abdominal mass, though it might be obscured by guarding or distension.
And if the rupture is maybe contained for a moment, bleeding into the space behind the abdomen, are there any specific bruising signs to look for, though maybe they take time to show up?
Yeah, they're often late findings, but very specific.
Mm.
We look for ecchymosis, bruising. If it's on the flanks, that's the gray Turner sign.
Okay.
If it's around the umbilicus, the belly button, that's the Cullen sign. Finding those strongly suggests a massive retroperitoneal hemorrhage.
And the prognosis here is grim. Untreated rupture mortality is over 90%. Just devastating.
So given that severity, the decision-making in the emergency department has to be incredibly fast. If a patient rolls in, hypotensive, maybe with known AAA,
Yeah.
do you waste time with fancy imaging? Absolutely not. Time is everything. If the patient is unstable and you know they have a AAA, the rule is skip all non-essential imaging, go directly to the operating room now.
And if they're unstable but you don't know if they have an AAA?
Then the tool is a quick bedside ultrasound. A focused abdominal ultrasound, fast exam style, looking for an aneurysm and any free fluid. It's fast and can confirm the likely diagnosis.
So when do you get the CT scan, the gold standard CT angiography?
Only if the patient is hemodynamically stable. If they're stable enough, then yes, a CTA with contrast gives crucial anatomical detail for surgical planning. But stability comes first. Instability means OR immediately.
Makes sense. Before we move on from AAAs, you mentioned a specific post-surgical risk tied to that infrarenal repair. We need to talk about ischemic colitis.
Yes, this is a key complication to anticipate, especially after open repair below the renal arteries.
Why does it happen?
Well, the infrarenal aorta sits right above the origin of the inferior mesenteric artery, the IMA.
Which supplies?
It's crucial for supplying the left side of the colon, basically the descending colon and sigmoid.
Okay.
During an open AAA repair, the IMA often has to be ligated, tied off permanently.
Okay.
Now, usually there's enough collateral blood flow from other vessels, but if the patient doesn't have good collaterals,
Then that part of the colon doesn't get enough blood.
exactly. Lack of blood flow leads to ischemic colitis. Patients typically present a few days after surgery with maybe fever, definitely lower left quadrant pain, LOQ pain, and often bloody diarrhea. It's serious and needs quick recognition.
Good to know. Definitely something to watch for post-op. Okay, so we've covered the AAA, that slow motion time bomb. Now let's flip to the complete opposite. Conditions where the failure is sudden, instantaneous. Starting with aortic dissection, defined by that sudden tearing inside the vessel wall. How is this fundamentally different from the degenerative ballooning of an aneurysm?
It's a totally different process. The driving force here is sheer stress and usually high blood pressure, not that slow chronic degeneration. A dissection starts with a sudden tear in the intima, the very inner lining of the aorta.
Right.
Then, blood under massive pressure surges through that tear and violently splits the layers of the media, the middle layer. It carves out a new channel within the wall itself.
Creating a second path for blood flow.
Exactly. That's called the false lumen. And as this false lumen expands, it can compress the original true lumen, cutting off blood flow to crucial branch arteries, the ones going to the brain, arms, kidneys, gut, legs.
And what's the primary force ripping that initial intimal tear?
Uncontrolled hypertension. Chronic high blood pressure creates immense mechanical shear stress against that inner lining.
So hypertension is the big one.
Overwhelmingly the most common underlying risk factor. Sure, certain connective tissue disorders like Marfan or Ehlers-Danlos make the aorta inherently weaker.
Okay.
And things like cocaine use can cause sudden severe pressure spikes. But day in, day out, chronic uncontrolled hypertension is the main culprit.
The clinical presentation is critical here because it's often so specific. How does the patient usually describe the pain? And how does the location of that pain help us figure out what's going on?
The pain is the signature symptom. It's typically sudden onset, absolutely excruciating, and often described with very specific words. Tearing or ripping.
Okay, tearing or ripping, and the location.
Location is probably the most important clue for classifying the dissection, which dictates management. If the pain is mainly in the anterior chest, radiating maybe to the neck or jaw, you immediately suspect the dissection involves the ascending aorta, the part right off the heart. That's a Stanford type A dissection.
Got it. Type A ascending front chest pain.
Right. But if the pain is primarily in the back, classically between the shoulder blades, the interscapular region, that usually points to a dissection involving only the descending aorta, the part going down the chest and abdomen. That's a Stanford type B.
That distinction is crucial. Beyond the pain itself, what other diagnostic clues might we find that suggest a major vascular catastrophe is happening?
Well, you look for signs that those branch vessels are compromised. A classic finding is a pulse deficit, meaning a significant difference in blood pressure measured between the two arms. Maybe one arm has much lower pressure or even no pulse. That happens if the false lumen squashes the origin of the subclavian artery feeding that arm.
Okay, pulse difference. What else?
Another critical finding is listening to the heart and hearing a new diastolic murmur, usually a blowing sound, heard best along the left side of the sternum.
And what does that indicate?
That points to acute aortic regurgitation. The dissection is torn backwards towards the heart and damaged or distorted the aortic valve, causing it to leak severely. That's a life-threatening complication.
So this classification, Stanford type A versus type B, you said it's the most critical distinction for management. It separates immediate surgery from potentially starting with medical management. Why is type A the absolute surgical emergency?
Because type A involves the ascending aorta right next to the heart. The potential complications are immediate and often fatal.
Such as?
Well, if the dissection ruptures outward into the pericardial sac around the heart, you get cardiac tamponade. Blood fills the sac, crushes the heart, kills the patient quickly.
Wow.
If the tear extends into the coronary arteries, which branch right off the ascending aorta, it causes a massive heart attack, an MI.
Right.
If it wrecks the aortic valve, like we just mentioned, you get sudden severe heart failure. Because of these catastrophic risks, type A requires emergent surgical repair. They have to replace the damaged descending aorta, sometimes the valve too, no delay.
Okay, type A equals RR fast. Conversely, type B involving only the descending aorta allows for an initial period of medical stabilization, you said.
Correct. If it's only the descending aorta, the immediate life threats are generally lower. So the initial approach is aggressive medical management.
What's the goal of that management?
The primary goal is to reduce the stress on the aortic wall, minimize the shear forces that are trying to propagate that tear, make the false lumen bigger.
How do you do that?
Strict blood pressure and heart rate control. We use intravenous beta blockers, first drugs like Usmle or labetalol, to rapidly slow the heart rate and decrease the force of each heartbeat. Then we had other agents, maybe vasodilators, to bring the systolic blood pressure down aggressively, usually aiming for a target around 100, 120 millimole HG.
And you keep them on medical therapy unless?
Unless the dissection becomes complicated. That means things are going wrong despite medical management. Signs of end organ ischemia like kidney failure, bowel dying, limb ischemia, or signs of impending rupture like rapidly expanding size or persistent severe pain. Or if the pain just can't be controlled, then a type B needs intervention, either endovascular stenting or open surgery.
Okay, that distinction and management strategy is crystal clear. Let's pivot now from spontaneous tearing inside the aorta to tearing caused by massive external force. Blunt traumatic aortic injury, or BTAI, what kind of trauma causes this?
BTAI is almost always caused by rapid deceleration. Think high-speed car crashes, motorcycle accidents, or falls from a significant height. The source is usually, quote, 3 meters or 10 feet. It's the sudden, violent stop that does the damage.
And just like the AAA had its weak spot, BTAI has a typical location too.
It does. The vast majority, something like 80–90%, occur at the aortic isthmus.
Where's that exactly?
It's the segment just distal to where the left subclavian artery branches off the arch. It's the transition point where the relatively mobile aortic arch connects to the descending aorta, which is much more fixed, tethered to the back of the chest wall.
Ah, so mobile part meets fixed part.
Right. When the body suddenly stops, inertia keeps the arch moving for a split second longer than the fixed descending part. That creates an immense shearing force right at that junction, the isthmus, and causes a tear or transection.
Makes sense. In the trauma bay, someone comes in after a major MVC. Besides obvious chest injuries like rib fractures, what clinical findings should raise immediate suspicion for BTAI?
You're looking for chest or back pain, obviously. Bruising over the sternum is a big clue. Fractures of the sternum or scapula. First rib fractures are also associated.
What about screening tools?
The initial screen is often the chest X-ray. You're looking specifically for a widened mediastinum,
How wide?
usually defined as greater than 8 centimeters, measured at the level of the aortic knob. While that's sensitive, it's not super specific.
Are there any more specific, though maybe rarer, signs?
There's a classic triad mentioned, though it's rare. Upper extremity hypertension combined with diminished or absent femoral pulses down in the legs. That directly reflects the blockage at the isthmus.
Okay.
And occasionally hoarseness can occur. It's called Ortner's syndrome, actually, though some sources might use Rennie. It happens if the hematoma stretches the left recurrent laryngeal nerve, which loops under the aortic arch.
Interesting. So once BTAI is suspected, based on mechanism or initial findings, what's the immediate management priority? It sounds familiar.
It should. It's exactly the same initial priority as for stabilizing an uncomplicated type B dissection. Strict blood pressure control.
Why?
You need to reduce the shear stress on that damaged, potentially partially torn aorta, prevent a contained injury from becoming a free catastrophic rupture into the chest. So again, IV beta blockers aiming for a systolic BP between 100 and 120 mmHg and reduced heart rate.
And then, assuming the patient is stable enough after initial resuscitation?
Then the gold standard for diagnosis and planning is CT angiography. CTA gives you the precise location and extent of the injury.
And the definitive repair these days.
For most BTAI, it's now endovascular repair with a stent graft, often called TEVAR, thoracic endovascular aortic repair. It's largely replaced open surgery because it's less invasive, has better outcomes, and quicker recovery.
Makes sense. Okay, final topic in this acute catastrophe section, extremity vascular trauma, arm or leg injuries involving major arteries. This is where the physical exam becomes absolutely critical, differentiating hard versus soft signs. What does finding a hard sign mean for management?
Finding a hard sign means you have likely diagnosed a significant arterial injury that needs immediate repair. It means skip the lengthy CTA scan, go directly to the operating room. Time is critical.
And what are those hard signs?
Pulsatile, squirting bleeding is the most obvious one. Hearing an audible bruit or feeling a palpable thrill over the injury site, seeing a rapidly expanding hematoma, or crucially, seeing clear signs of distal ischemia. The limb is cold, pale, has no pulse, or the patient can't feel or rev it properly.
So any of those means straight to OR.
Correct. No delay for imaging.
And if we only find soft signs, what are those and what do they trigger?
Soft signs suggest a potential injury, but not necessarily definite immediate flow compromise. These might include diminished pulses compared to the other limb, but they're still present. Or maybe just a history of significant bleeding at the scene that's now stopped, or a nerve injury close to the path of a major artery.
So with soft signs, we have a bit more time.
A bit more time, yes. If you only find soft signs, the next step isn't the OR, it's further assessment. The key assessment cited is the Injured Extremity Index, or IEI, sometimes called the Ankle Brachial Index, ABI, in the trauma setting.
How do you calculate that?
You measure the systolic blood pressure in the injured limb, usually at the ankle or wrist using a Doppler, and divide it by the systolic pressure in an uninjured arm.
And what reading indicates a likely injury?
An index less than 0.9 is considered abnormal and strongly suggests a significant vascular injury. That finding is the trigger to then proceed with imaging, usually a CTA, to pinpoint the injury before planning the repair.
Got it. But regardless of hard or soft signs, the overall message in vascular trauma seems to be urgency. What's the critical time window for revascularization we absolutely need to respect?
The sources are really clear on this. Delaying revascularization, getting blood flow restored beyond 6 hours, significantly increases the risk of irreversible muscle and nerve damage, leading to amputation and poor long-term function.
6 hours is the limit.
That's the widely quoted critical ischemic time. In reality, trauma teams aim for much faster intervention, often within just 2 to 4 hours if possible. But 6 hours is that absolute deadline you do not want to cross.
Okay, we've covered the acute structural failures. Let's shift back now towards chronic progressive disease, starting with peripheral artery disease, or PA. This is all about atherosclerosis, right? Plaque buildup blocking the large arteries to the limbs.
Exactly. We're talking about blockages in the aorta, the iliac arteries in the pelvis, the femoral arteries in the thigh, the popliteal arteries behind the knee. Classic atherosclerosis, just like in the heart or brain, but happening in the legs.
And the hallmark symptom.
Intermittent claudication. That's the defining symptom for most people initially.
Break that down for us. What is claudication?
It's muscle pain or cramping, most often felt in the calf, but it can also occur in the thigh or buttock. The key features are, it's consistently brought on by exercise, like walking a certain distance.
Okay.
And it's predictably relieved by a short period of rest, usually just a few minutes.
Why does that happen?
It's basically an oxygen supply and demand mismatch. At rest, the narrowed arteries can deliver enough blood, but during exercise, the muscles demand much more oxygen, and the blocked arteries just can't keep up. That oxygen debt causes the pain.
Got it. Looking at risk factors again, we see some familiar ones, but in the context of PA, two really stand out as destructive forces.
Yes, smoking, again, is just terrible for PAID. It accelerates it significantly.
No surprise there. And the other?
Diabetes mellitus. While it might protect against AAA, diabetes is absolutely devastating for PAID. It tends to cause more diffuse disease, often affecting the smaller arteries below the knee, which can be harder to treat, and it accelerates the progression dramatically.
And this leads to a really crucial point the sources emphasize about PAID's significance.
Absolutely critical. PAID is considered a coronary artery disease, PAID risk equivalent.
What does that mean practically?
It means if a patient has PAD, even if it's just leg pain when they walk, their risk of having a heart attack or stroke is just as high as someone who has already had one. So you must treat them with the same aggressive risk factor modification statins, blood pressure control, antiplatelets as you would a patient with known heart disease. It's a marker of systemic atherosclerosis.
That's a really important takeaway. Now, the location of the blockage matters for symptoms. If the blockage is high up, near the aorta-iliac bifurcation in the pelvis, we get a specific cluster of symptoms called Leriche syndrome. What's the classic triad for that?
Leriche syndrome points to that high-up occlusion. The triad is, first, bilateral claudication. Pain affects both legs, typically in the large muscles, hips, thighs, buttocks.
Okay, both sides, high up.
Second, you find diminished or completely absent femoral pulses when you examine the patient in the groin.
Makes sense, blockage is above that point.
And third, because the blockage affects blood flow through the internal iliac arteries, which supply the pelvic organs, men often experience erectile dysfunction, or ED. That combination, bilateral buttock-thigh claudication, absent femoral pulses, and ED is highly specific for aortoiliac occlusion.
Good try to remember. For diagnosis, symptoms are suggestive, but we need objective proof. What's the gold standard non-invasive test and what value confirms PAD?
The gold standard initial test is the ankle brachial index, or ABI.
How's that done again?
You measure the highest systolic blood pressure at the ankle using a Doppler probe over the arteries there and divide it by the highest systolic pressure measured in either arm.
Simple ratio.
Simple ratio. And an ABI of 0.90 or less is diagnostic of TA. The lower the ABI, generally the more severe the disease.
Okay, AB29 means PD. But you mentioned earlier, especially with diabetics, there's a critical exception or tricky reading we need to watch out for.
Yes, absolutely crucial point. You need to be very wary of an ABI that is artificially high, specifically greater than 1.3.
Why would it be high if they have blockages?
Because this doesn't mean the vessels are healthy. It usually means the arteries, particularly the ones below the knee, are severely calcified, hardened like pipes. It's a condition sometimes called Monckeberg's arteriosclerosis, common in diabetics and those with kidney disease.
And the cuff can't squeeze them.
Exactly. The blood pressure cuff can't compress these rock-hard vessels properly, so you get a falsely elevated ankle pressure reading. An ABI 1.3 is unreliable and might actually mask severe underlying blockages.
So what do you do then if the ABI is 1.3, but you still suspect PD?
You need other tests. Often you'd move to measuring toe pressures using smaller cuffs as the toe vessels are less likely to be calcified, or you'd go to imaging like duplex ultrasound to directly visualize the plaques and flow.
Okay, really important caveat there with the high ADI. Once PA is confirmed, what are the cornerstones of management? What do we do for these patients?
The management strategy has several key pillars. First and foremost is aggressive risk factor modification. Smoking cessation is number one, absolutely non-negotiable for slowing progression. Then, medication is crucial. All PID patients need high-intensity statin therapy, aiming for an LDL cholesterol below 70 mg/dL, ideally even lower.
Statins, got it.
And they need antiplatelet therapy, usually aspirin or clopidogrel, for secondary prevention of heart attack and stroke, because remember, it's a CAD equivalent.
Makes sense. What about treating the claudication symptoms themselves, the leg pain?
For the symptoms, the first-line therapy, strongly recommended by guidelines, is a supervised exercise program.
Just walking.
Essentially, yes. Consistent walking, usually 30 to 45 minutes, at least 3 times a week, pushing into the claudication pain, resting, then starting again. It sounds simple, but it's highly effective.
How does it help?
It forces the body to adapt by developing collateral circulation, tiny new blood vessels that bypass the blockages. Over time, this improves blood flow and allows patients to walk further without pain.
Fascinating. Exercise is medicine. Okay, now let's consider when this chronic PAD suddenly gets much worse, leading to acute limb ischemia, or ALI. This is when the oxygen supply gets cut off abruptly.
Right. ALI is a rapid, sudden decrease in blood flow to the limb, developing usually over hours or maybe a few days. It's a vascular emergency.
What causes it? What are the main mechanisms?
There are 2 primary causes, and knowing which is likely helps guide treatment. About 60% of cases are due to embolism.
A clot from elsewhere.
Exactly. A clot travels from a distant source and lodges in a leg artery. The most common source is the heart, usually due to atrial fibrillation, where clots form in the poorly contracting atrium, or maybe a clot formed on the heart wall after a large heart attack.
Okay, embolism is most common. What's the other cause?
The other 30% or so are due to thrombosis. This is where a clot forms right at the site of a pre-existing atherosclerotic plaque within the leg artery, usually in a patient who already has known PAD. The plaque ruptures or flow becomes very sluggish and a clot forms locally, suddenly blocking the vessel completely.
Got it. Embolus from afar, or thrombus right there. The clinical presentation is famously summarized by the 6 Ps. Can you list those for us?
Sure, the 6 Ps are the classic signs and symptoms of ALI. They are pain, usually sudden and severe, pallor, the limb looks pale, white, pulselessness, absent pulses distal to the blockage, poikilothermia, the limb feels cold to touch compared to the other side, paresthesia, numbness, tingling, pins and needles, and finally paralysis, inability to move the foot or toes, muscle weakness.
And the appearance of those last 2 is particularly ominous, right?
Extremely ominous. Paresthesia and paralysis mean the nerves and muscles are becoming ischemic, starved of oxygen. This signals that the limb is immediately threatened or potentially already irreversibly damaged. Their presence dramatically shortens the time window for successful intervention.
This brings us to the crucial classification system for ALI, which dictates how quickly you need to act. Can you walk us through the Rutherford classes? I have a 3.
Yes, this classification is all about assessing limb viability and urgency. Class 1 is viable. The limb is painful, maybe pale and cool, but there's no sensory loss, no paresthesia, and no muscle weakness, no paralysis. Arterial Doppler signals are usually audible.
So still salvageable with some time.
Yes, revascularization is needed, but it's considered urgent, not quite emergent. We have maybe hours, perhaps time for catheter-directed thrombolysis using drugs to dissolve the clot.
Okay, class 1 is viable. What about class 2?
Class 2 is threatened. This is where the limb survival is in jeopardy. It's subdivided based on the presence of motor deficit.
Okay.
Class 3 is marginally threatened. Here, you have sensory loss paresthesia, maybe just in the toes or foot, but muscle strength is still intact. No paralysis. Arterial Doppler signals might be faint or absent.
In the time frame for DS?
This requires emergent revascularization. The goal is intervention within about 6 hours to avoid permanent damage.
6 hours. Now, class 4.
Class IB is immediately threatened. This is the critical stage. Here you have both sensory loss and now motor deficit muscle weakness, paralysis starting. The patient might have trouble wiggling their toes or flexing their ankle. Arterial Dopplers are usually absent.
And the time frame here? This sounds really bad.
It is really bad. This requires immediate revascularization. The window is incredibly short, ideally less than 2 hours. Any delay significantly risks amputation. This often means bypassing slower methods like thrombolysis and going straight for surgical embolectomy or bypass.
2 hours for IB. Wow. Okay, what's class 3?
Class 3 is irreversible. The damage is already done. The limb shows profound anesthesia, complete loss of sensation, and profound paralysis. Rigor might even be setting in. Critically, both arterial and venous Doppler signals are absent. The limb tissue is effectively dead or dying.
So revascularization isn't an option here.
Generally, no. Attempting revascularization at this stage carries huge risks. When blood flow returns to dead tissue, massive amounts of toxins, potassium, acid, muscle breakdown products get washed back into the systemic circulation, which can cause kidney failure, cardiac arrest, and death. So, sadly, Class 3 usually means primary amputation is the safest option to save the patient's life.
A grim outcome, but necessary. Regardless of the class, though, what's the very first step in managing any patient with suspected ALI while you're figuring out the class and planning intervention?
Immediate anticoagulation. As soon as you suspect ALI, you start the patient on intravenous heparin
Why?
to prevent the clot from propagating, getting bigger, and blocking off more collateral vessels. It buys you time while you assess the severity and arrange for the definitive revascularization procedure, whether that's surgery or thrombolysis. Heparin first, always.
Okay, heparin immediately. Now, the final topic in this section is a feared complication that can arise from both trauma and, importantly, after successfully treating ALI. Compartment syndrome. This is about pressure, right? Not just lack of flow initially.
Exactly. Compartment syndrome is another limb-threatening emergency. It happens when pressure builds up inside a closed fascial compartment. These are the tight connective tissue bundles surrounding groups of muscles, common in the lower leg and forearm.
And the pressure gets too high.
Yes. The pressure inside the compartment increases so much that it exceeds the pressure in the capillaries, supplying blood to the muscles and nerves within that space. Blood flow gets cut off because of the high pressure.
What causes the pressure to rise like that?
Two main scenarios. Severe trauma is a common cause, especially fractures like tibial fractures, where you get a lot of bleeding and swelling directly into the compartments.
Makes sense. And the other scenario, related to what we just discussed?
The other classic cause is reperfusion injury. After you successfully open up a blocked artery and restore blood flow to an ischemic limb, say, after an embolectomy for ALI, the previously starved tissues react. Capillaries become leaky, and fluid pours out, causing massive swelling. That swelling, trapped within the tight fascial compartment, rapidly jacks up the pressure.
So fixing one problem can cause another. What's the absolute key clinical sign, the one thing that screams compartment syndrome?
The pathognomonic sign is pain out of proportion to the apparent injury. But more specifically, it's severe pain on passive stretch of the muscles within the affected compartment.
Can you give an example?
Sure. If you suspect compartment syndrome in a lower leg, gently and passively dorsiflexing the patient's ankle, stretching the calf muscles, or extending their toes, stretching the muscles on the front, will cause excruciating pain. The compartment itself will also feel very tense, swollen, and hard to the touch.
Pain on passive stretch. Got it. Diagnosis is mainly clinical suspicion then.
Primarily, yes. High index of suspicion based on the setting, trauma, post-revascularization, and that key sign. But you can confirm it by directly measuring the pressure inside the compartment using a special needle and transducer.
And what are the pressure readings that confirm it?
There are two main criteria used. One is an absolute compartment pressure greater than 30 millimilli Hg.
Okay.
But perhaps a more physiologically relevant measure is the delta pressure. This is calculated as the patient's diastolic blood pressure minus the measured compartment pressure.
Why diastolic?
Because diastolic pressure roughly represents the pressure driving capillary perfusion. So if the difference between diastolic BP and compartment pressure is small, it means the pressure outside the capillaries, compartment pressure, is almost as high as the pressure trying to push blood into them.
So what's the critical delta pressure value?
A delta pressure less than or equal to 30 millimilli Hg is considered diagnostic of compartment syndrome and indicates urgent need for intervention.
That makes the pathophysiology really clear. So once you diagnose it, what's the treatment?
The only definitive treatment is emergent fasciotomy. You have to surgically cut open the overlying fascia of all the affected compartments to release the pressure immediately.
How quickly does that need to happen?
Urgently. Ideally, within that same critical 6-hour window from the onset of symptoms or the inciting event to prevent irreversible muscle death, necrosis, and nerve damage.
6 hours again seems to be a magic number in vascular emergencies. And finally, one really important, maybe counterintuitive point about immediate care while waiting for the fasciotomy. What should you not do?
You absolutely should not elevate the limb.
Really? We usually elevate limbs to reduce swelling.
Right. But in compartment syndrome, elevation is contraindicated. Elevating the limb actually lowers the arterial pressure head driving blood flow into the already compromised compartment. It can worsen the ischemia. So keep the limb at the level of the heart or even slightly dependent. No elevation.
Crucial point. Keep the limb flat or down. All right, before we wrap up this deep dive into all the specific vascular conditions, let's just briefly connect things back to a broader systemic disease example, and then cover the essential non-clinical framework that underpins all these high-stakes decisions. Informed consent.
Sounds good. Starting with the systemic link, let's quickly touch on ankylosing spondylitis, or AS.
Which is primarily a disease of the spine, right?
Yeah.
Inflammatory arthritis?
Exactly. It's a chronic inflammatory rheumatological disease, mainly hitting the spine and the sacroiliac joints in the pelvis. But it's a great example of how systemic inflammation doesn't always stay localized.
So what's the specific vascular complication our sources highlight with AS?
In some patients, particularly those with long-standing severe disease, the inflammation can actually extend beyond the joints and affect the base of the aorta, right where it leaves the heart. The key complication is aortic regurgitation, or AR leaky aortic valve. This happens because the chronic inflammation causes fibrosis and thickening of the aortic root and sometimes the aortic valve leaflets themselves, preventing the valve from closing properly.
And it's specifically the aortic valve.
Yes, that's the characteristic lesion in AS. It doesn't typically affect the mitral or tricuspid valves. So if you have a patient with known AS who starts developing symptoms like shortness of breath on exertion, or you hear a new diastolic murmur.
You need to think about AR.
Exactly. The next step would be an echocardiogram to directly visualize the aortic valve and root and assess the severity of the regurgitation.
That's a really interesting link spine inflammation leading to a potential cardiac valve issue. Okay, now let's shift gears to the framework for actually doing all these interventions we've discussed. Given the significant risks involved, rupture repair mortality, dissection complications, limb loss with ALI or compartment syndrome, the process of informed consent becomes incredibly important.
Absolutely. It's not just a form to sign. It's a fundamental ethical requirement. It's all about respecting the patient's autonomy, their right to make decisions about their own body.
And for consent to be valid, there are two absolute preconditions.
Yes. The patient must have competency, also called decision-making capacity. They need to be able to understand the relevant information and appreciate the consequences of their choices.
Okay, competency. And the second?
The decision must be made voluntarily, free from coercion or undue influence from doctors, family, or anyone else.
Makes sense. Now, the sources are quite clear on what information must be disclosed during the consent discussion, often summarized as the essential 5. If we're consenting someone for, say, an elective AAA repair, what 5 things do we absolutely have to cover?
Okay, the essential 5. 1. The diagnosis. Clearly state their current medical condition. You have a 6-centimeter abdominal aortic aneurysm, which puts you at high risk of rupture.
Clear diagnosis?
2. The proposed treatment. Explain the general nature of the procedure you're recommending. We plan to repair this using an endovascular stent graft placed through small incisions in your groin.
Okay. 3.
3. Alternatives. You must discuss all reasonable alternatives, including doing nothing. Other options include open surgical repair, which involves a larger incision, or continued observation without surgery, although that carries the risk of rupture.
Alternatives, got it. 4.
4. Risks and benefits. This is crucial. You need to discuss the potential benefits preventing rupture, extending life, but also the significant risks. Focus on the common complications like bleeding, infection, groin hematoma, and the rare but major ones like death, stroke, paralysis, kidney failure, graft infection or blockage, or that ischemic colitis we talked about.
Common and serious risks. And 5.
5. The risks of refusal. What are the likely consequences if the patient chooses not to have the proposed treatment? If left untreated, the aneurysm is likely to rupture, which is usually fatal.
Diagnosis, treatment, alternatives, risks, benefits, risks of refusal, the essential 5. What kind of information are we generally not required to go into to avoid just overwhelming the patient?
Yeah, you don't need to provide a highly detailed step-by-step account of the surgical technique that's usually not helpful for patient understanding. You're also generally not required to discuss financial costs during the medical consent process, though that might be a separate conversation.
Okay.
And crucially, you don't have to list every single conceivable complication that has ever been reported in the medical literature. It's impractical and frightening. The focus should be on the risks that are reasonably common or particularly severe and relevant to this patient in this procedure.
That makes sense. Tailor it. And finally, the documentation aspect. A signature on the form isn't the whole story, is it?
Not at all. The signed consent form is just evidence that a discussion happened and the patient authorized the procedure. The critical legal and ethical requirement is the documentation of the consent process itself in the medical record.
What should that documentation include?
It should detail that the essential 5 were covered, which specific major risks were discussed, that alternatives were offered, that the patient had the opportunity to ask questions, and importantly, an assessment that the patient appeared to understand the information and agreed voluntarily. That narrative note is arguably more important than the signed form itself. #outro. So as we wrap up this deep dive, I think the core insights really circle back to classification and time. Vigilance is key, like the recommendation for one-time ultrasound screening for AAA in older men with a smoking history. That saves lives.
Yeah.
And then the need for precise, rapid classification during acute events. Knowing immediately if it's a Stanford type A dissection needing surgery versus a type B for medical management.
Or differentiating ALI class TIA with a 6-hour window from IBRU with only 2 hours.
Exactly. That speed and accuracy is paramount. And underlying almost everything we talked about, AAA, dissection, PAD, BTAI complications, are those pervasive damaging risk factors, especially smoking and uncontrolled hypertension.
Absolutely. Those timing differences really define the field. And we definitely pulled out some memorable takeaways. Understanding the infrarenal aorta's weakness due to fewer vasa vasorum.
That diabetes paradox, protective for AAA, destructive for PD.
Right. Knowing the hard versus soft signs in trauma that dictate skipping imaging. Mastering the ABI, especially at that tricky 1.3 reading.
And remembering the 6 Ps for ALI and the delta pressure rule for compartment syndrome. Crucial stuff.
And the sources were so clear that peripheral artery disease isn't just leg pain, it's a full-blown coronary artery disease risk equivalent.
Mandating that aggressive systemic treatment, statins, antiplatelets, BP control, even if the only symptom seems peripheral. It forces you to think about the patient's total vascular health.
And that really leads perfectly into our final provocative thought for you, the listener. If PA, a peripheral problem, demands treatment as aggressive as heart disease,
then what's the full spectrum of other silent non-cardiac vascular conditions we should perhaps consider as mandatory CAD equivalents? Think about asymptomatic carotid stenosis or undiagnosed renal artery stenosis.
how does taking this concept of total body vascular health really seriously, driven by the aggressive risk management we learned from PA, fundamentally change how we should approach preventive medicine for essentially every patient?
Something to definitely mull over as you digest the high-stakes lessons from today's deep dive. Thanks for learning with us.